joining us today for the 5th event in our ongoing series of virtual COVID-19 vaccine town halls presented by the Globe and Mail and the Royal Society of Canada. I'm Andrea Wu, health reporter for the Globe and Mail, and I am pleased to be your MC and moderator for today's discussions. The Globe and Mail and the Royal Society of Canada have been collaborating for a number of months now on this series of town halls. Our hope is that these events will provide a public good in presenting the information Canadians need in the fight against COVID-19 from leading experts across the country. Before we get started and introduce our expert speakers, I have a few housekeeping items to attend to. For viewers, if you are experiencing any technical difficulties, please let us know either via the ask box on your screen or by emailing marketing@globeandmail.com, and your question will be answered as soon as possible. Our team has been working hard to ensure that everyone has the best tech experience possible, but you know how these things go. And in the event that we run into any sort of difficulties, please bear with us and we will get you back up and running as quickly as possible. Thank you to those who have sent in questions ahead of time. You can also ask a question during the panel by using the same ask feature on your screen. We'll take a few of your questions closer to the end of the discussion. Everyone who registered for the webcast will receive a link to the recorded version so you can view the event again at your convenience. And in case you missed them, the link featuring the event playback will also include videos from all 4 of our previous vaccine town hall events from earlier this year. That link will also feature further resources where you can find out more information about COVID-19, including coverage from the Globe and Mail, policy briefings from the Royal Society of Canada, and information about the Globe and RSC's collaborative Zero Canada project. You can take a look at all of those resources at the links you see on screen here. If you'd like to follow the social media conversation happening around today's town hall, please follow @RSC The Academies for live tweets from today's event, as well as to stay up to date on news and events from the Royal Society of Canada. You can also follow @The Globe Events for updates from the Globe's events team. Without further ado, we will now get to today's panel discussion. The focus of today's conversation is, I've taken the vaccine, now what? Our hope is to offer some clarity on the subject and answer some pressing questions from our audience. Joining us today are 4 experts in the field. I'd first like to introduce everyone to Dr. Scott Halperin, a professor of pediatrics, as well as microbiology and immunology at Dalhousie University. He is the director of the Canadian Centre for Vaccinology as well. Welcome, Dr. Halperin. Next, we'd like to welcome Dr. Gina Ogilvie, a professor at the University of British Columbia, as well as a senior public health scientist at the BC Centre for Disease Control. Hello, Dr. Ogilvie. I'd also like to welcome Dr. Alika Lafontaine, an Indigenous health advocate and an anesthesiologist for Alberta Health Services. I should also note that Dr. Lafontaine is the president-elect of the Canadian Medical Association and will be the first Indigenous person and first Pacific Islander to take on this role. Congratulations and welcome, Dr. Lafontaine.
Thank you.
And last but not least, please join me in welcoming Professor Colleen Flood, Director of the University of Ottawa Centre for Health Law, Policy and Ethics. Hello, Professor Flood.
Hey, everybody. Lovely to be here.
So I'd like to start by asking all of our panelists for just a brief overview of what you all think the next big issues will be now that a majority of the Canadian population, about 58% as of today, has received at least 1 dose of the vaccine, and just under 6% have been fully vaccinated. Dr. Halperin, we'll start with you.
Sure. I mean, I think the important things now are going to be how we go back to normal and move towards normalcy with vaccines, particularly once we start getting the second doses in as well and have high rates of population immunity, and trying to understand whether we are able to achieve herd immunity. And if we are, how do we do that? And how do we do that here in Canada? And how do we do it when Canadians leave or when Canadians come back? I think those are going to be very important issues. And then I think a second very important is the issue around immunization of younger children as vaccines become available to them, and we get them back into those areas where there's a lot of mixing, schools, daycares, and the like. So I think those are the most important areas of interest and where research needs to inform public health policy.
Thank you for that. Dr. Ogilvie?
Thanks, and thank you so much for the invitation and to the Globe and the Royal Society for hosting this. I agree with Dr. Halperin. I think those are some of the key issues. I want to add to that while we have 58% of the population, overall vaccinated, we're aiming for even higher levels. So we need to continue to focus on vaccine confidence and vaccine hesitance. The WHO named vaccine confidence and hesitance as one of the top 10 public health issues. And I think we've really seen the importance of vaccines and the importance of supporting folks who have concerns and questions. So how are we creative and innovative in terms of getting vaccines to those priority communities and communities that have concerns? I also think we're increasing data showing that the variants are important, and getting that second dose in is going to be really important. So supporting and expanding and making sure there's as much rapid uptake of those second doses as soon as they become available is going to be really important. I think from a public health lens, one of the key things that may not be as directly of interest to the public right now, but I think is something we have to think about is how are we continuing to monitor? So right now we can use sort of general public health testing to do that. But as cases drop, we're going to need to think a bit more creatively about how do we monitor for variants, and how do we share that data? How do we share it quickly, efficiently, make sure that across the country, we all know what is going on and what's happening. And then I think the third sort of priority I would just touch on to a little bit again to what Dr. Halperin talked about is as we move to sort of reopening society, really tackling some of the mental health sort of consequences of our lockdowns, but also thinking about particularly our elderly population and our youth who really shouldered the largest burden of this, and how do we support them as they move forward in society. So those would be some of the areas I would say are key for us to focus on.
Thank you so much for that, Dr. Ogilvie. Dr. Lafontaine?
So just to add to what has been shared already, I think the greatest challenge in this whole pandemic has really been managing expectations. In the province that I live in, we're having leadership talk about the best summer ever. I mean, we haven't reached herd immunity yet. We still have a ways to go before getting to that intermediate phase of the pandemic. So it's just important for people to know that this will go on for a while, even though we'll reach herd immunity, and hopefully any subsequent waves won't have the same sort of peaks that we've experienced already after this third wave, that we may still need, public health guidance to help change the way that we interact with each other, just to make sure that we avoid those impacts on society. The second part is that COVID really hasn't been spread across society and the burden of it shared equally. We call places COVID hotspots or demographics vulnerable, but in reality, these are groups that have wide disparities when it comes to social determinants. Folks in long-term care, racialized populations, those with physical disabilities, low income, working moms, hit among others. We also have children who've gone through, education over the past year being forced into online learning. We don't really know what's going to happen with all of that. So it's important as we get excited about what happens after, not to forget that we still have these problems that have been shown in COVID. We need to still measure related to data, not just to vaccines, but the outcomes on these demographics and vulnerable populations. And we need to make better decisions when it comes to supporting them, because we do know from previous pandemics that certain groups don't recover after pandemics finish. And finally, I'll just underscore just how tired and exhausted healthcare workers are. Personally, I had a time where I didn't stop working from, mid-August until late March, and just had a few days off during the December slowdown. Health systems are going to want to ramp up services, and you have an exhausted workforce. And we talked about the system breaking, but the system actually did break. We did many things that we never should have even considered doing. Transporting ICU patients in large amounts out of provinces like in Manitoba, canceling scheduled surgeries and scaling down capacity because we were waiting for COVID surges, putting healthcare workers in dangerous situations, both physically and emotionally. I mean, historically, the way that the healthcare system is designed is probably not what it needs to be designed around in the future. So how are we going to rebuild that capacity in a different way? So if we do have other pandemics or other stresses on the system, we can be ready for it. And the burden of that change doesn't need to be held by patients and by healthcare workers.
Thank you so much for that, Dr. Lafontaine. Professor Flood, what do you think are the next big issues we're going to be looking at?
Yeah, just to build on what Dr. Lafontaine just said, that I would just want to concur that the system did break, but one thing that wasn't mentioned was how badly the long-term care system broke. And, you know, the fact that we had the military going in as witness to that carnage, I think we just must remember that that is an important part of the system as well. And I think perhaps along those lines, I think the biggest mistake that we've made again and again throughout this pandemic, and I think as we're still making, is that we just want it to go away. We wish it is over, but wishing, the virus doesn't care about your wishes or your hopes, you know, just doesn't care at all. And, you know, we keep rushing too quickly, I think, to reopen because there are various pressures from various groups to do so. I think we need to go slowly and we need to be evidence-based as we start to reopen. We need to be cautious and we need to apply the precautionary principle as we start to think about reopening. So I don't think we're out of the woods yet at all, despite you know, the willingness of Canadians from coast to coast to roll up their sleeves. And I think the variants of concern are a real issue for us to deal with and manage. I know that there are a lot of questions about travel, and that's an example of you know, just the wanting this to all be over, so we can open up and get back to, you know, traveling the world and doing all the great things that we used to be able to do. I think, you know, there is a danger of variants of concern being re-imported back into Canada. And then, you know, with people only having 1 dose and even 2 doses, that in some circumstances, if new variants emerge, that the vaccines may not be as effective against those variants. So we have to really be careful how we do this. You know, this idea that we just go back to normal in a couple of weeks or this summer, I think that's just, in my view, very, very problematic, and I think too great a risk for Canadians to take after everything that everybody has been through this last year. So, you know, I think that's where we're at in my view, and we can start to think about all the things that will come after. But I think we've still got a way to get through.
Those remarks sort of made me smile, because I'm looking ahead at all of the questions that we have from audiences, and it's about all of the things that we want to do. How soon can we do them? I'd like to get into some of those. We got a number of questions in advance, and I figured I would just put them to you guys, and we can continue the conversation that way. The first question that we have is from David F., who says, we are aware of protocols for COVID safety, but now that I'm vaccinated, what is considered safe behavior for meeting with others who have had their first shot over 2 weeks ago? Obviously, the risk is very different to meet with friends who I know are vaccinated than before vaccination, but we are told nothing about that. Can I meet them indoors? Do we have to wear masks? What is considered appropriate and safe now that we have had our first shot? Perhaps Dr. Ogilvie, you could take that one on.
Thanks. And yeah, I really want to echo what my panelist colleagues have said. And I hear the sort of desire to sort of get back to normal, to get back to what we're doing. But I think what you can see in every province, and I think provinces have approached it differently, is they have, though, laid out reopening plans. And they've been really clear in most provinces that there's a stepwise approach that we need to see, and we need to sort of meet the sort of criteria, meet certain thresholds before we get to the next phase. So while I hear the sort of desire from David to kind of get back to normal, and I've got 1 dose, what we've been saying for folks with 1 dose is you simply still need to keep following the protocols that have been very clearly laid out. And that's because it's important that not everyone is vaccinated and not everyone has had the chance to receive that dose. So I know it's not necessarily what you want to hear, but I think what's important is that we follow the guidelines that are laid out within your province, and that we get to those thresholds. And then when we all reach the appropriate thresholds, we can move to the next stage.
Thank you for that. I'm combining two audience questions for the next one, and they're both basically about how much protection we have now. What is the effectiveness rate for those of us with only one shot? How quickly does that decline? And what about after two shots? Are we fully immune to COVID-19 and its variants? If not, what is the probability of still getting it? Perhaps Dr. Halperin?
Sure. So the vaccines, it depends on what vaccine somebody got in terms of what the efficacy was in the clinical trials. And then there's also how do they work in the real world. We have some estimates that, for example, the mRNA vaccines appear after a single dose to be in the 80+% effective range. And that rises up to mid-90s, 95% effective after a second dose. So, but one has to remember, those are global numbers, and you don't know whether you're the 5% or the 20% that after one dose or two doses that is not protected. So that, getting back to what was previously said, one has to still follow those other public health recommendations until the whole population immunity is so high that we hope the virus is not circulating anymore, because that's when we really have protection, when the virus is not circulating because of those high levels of immunity. A person who did not respond and might be, even with a great vaccine that's 95% effective, that might still be susceptible. They're in that 5%. They can get infected, and perhaps the vaccine will provide some benefit to them, but they may still be very susceptible, and they may have get the infection just as if they hadn't been immunized at all. So one can't depend, it's not an impenetrable shield. Vaccines are a tool that we use to increase both our own immunity as well as the immunity of the community, but they're not an impenetrable shield. So those other measures are very important.
Just sort of on a related note, there's a separate question. Do you expect annual boosters will be required?
It's a good chance that annual boosters will be required. We don't know enough about this virus yet. We certainly know that there are variants that are emerging, and some of those variants will perhaps escape the immune response that we've had from the vaccine. And we also don't know, because we haven't had these vaccines long enough around to know how long the protection lasts. So there are two reasons why we might need a booster. One is if our own immune response starts to fall off over time and we need to have a boost of that immunity back up. But we also may need to have a booster because the vaccine needs to be modified a little bit to reflect the change in the virus. So it's still too early to tell, but most people are predicting that we will need some boosters, but how frequently, that's still yet to be determined.
Thank you for that. As people start thinking about later on in the year and potentially things getting better, we hear a lot about vaccine passports. Will we likely be required to show proof of vaccination to travel or to attend large public events? Can there be a requirement for some office settings, some other work settings? What are some of the important considerations here, Professor Flood?
Yeah, so when folks talk about a vaccine passport or vaccine certificate, they're actually talking about a whole lot of things at one time. But essentially, a vaccine passport, a vaccine certificate is just simply, a proof that you've been vaccinated, and hopefully with the details of the kinds of vaccinations, second dose, et cetera, so one can assess the sort of level of immunity that one has. And the idea of it is that, you would have a QR code, perhaps if it's digitalized, that you'd be able to flash this thing, and perhaps that would permit you entry into things, as we've seen, like hockey games or rock concerts. It may be used at borders, and not that it may be, it will be used at borders by different countries, requiring people to show proof of vaccination before entry, in lieu of, for example, quarantine. So I'm speaking to you from New Zealand right now, my other country that I love in the world apart from Canada. And to come here, I had to go into a 2-week hotel quarantine here because there is no community transmission here. So we in New Zealand, there is no disease at all, which is a wonderful, wonderful thing, which has been achieved without vaccinations, right, using the other kind of measures. But eventually, as New Zealand starts to open up, they will probably permit people to come, provided they have proof of vaccination and perhaps a rapid test at the border. So it'll be in lieu of, you know, other kinds of requirements that we presently have. So folks have a lot of reactions to the idea of a vaccine passport or certificate. Some people are happy enough to think about it crossing borders. Basically, they won't have much choice because if another country, for example, the United States, says they need to see that before they're going to allow you entry, then that's just what you're going to have to do. But they have much more different reactions if we're talking about entry to a rock concert or an event or something along those lines. Perhaps because they are vaccine hesitant or they're anti-vaxxers or they just have concerns about discrimination, privacy, etc. So it has a bunch of worries around it. I myself think most of them can be dealt with. So for example, around discrimination, once we get to a level of herd immunity, then people who can't be vaccinated because of their underlying health conditions, then the QR code could still permit them entry into large events because we will have achieved that level of herd immunity. So I think there are different ways we can deal with it. I think the worry right now is that currently it's happening without any real government oversight. So private entities are starting to require proof of vaccination. And the government has sort of shied away from really getting involved with this because of the negative reaction to the idea of vaccine certificates and passports by a lot of folks. But I think that just means we will have a bit of a wild west of vaccine certificates. And I'm not sure that that is a good idea myself because of these concerns that we have around discrimination, privacy, and access to essential services that we might want folks to have regardless of whether or not they have a vaccine certificate. I'm sure Dr. Lafontaine has thoughts on some of these worries as well.
Dr. Lafontaine, would you like to add to that?
Yeah, I just echo a lot of the concerns and guidance that was just shared. There was a Ledger poll that was done at the end of May. 1,529 Canadians were asked the question of whether or not vaccine passports or proof of immunization should become policies. And more than 60% of respondents said that they supported those. There was another poll that looked at vaccine passports being used before you're able to get on a flight, and 3/4 of Canadians in that poll said that they supported it. And so although people are hesitant, I think to a great degree, they understand that there is some logic behind this. I've been watching this pretty closely. No Canadian jurisdiction has indicated that they'll mandate vaccination, but there have been provinces that have come out and said or suggested that there might be restrictions. Places like Ontario, they had something that they said back in December. New Brunswick has talked about that. BC has talked about some sort of restrictions. The federal government has come out talking about some restrictions regarding international travel. So, this is going to happen in Canada to some degree. Places like the European Union and certain Asian countries have already started to scramble to put together some plans that way they can bring back international travel. But what I'll really underline is that the path back to normalcy is actually through vaccination. Despite our concerns around vaccine passports and proof of vaccination, the reason why we need these things is we're not having enough people get vaccinated at high enough degrees. And I'll just underscore the comment that was made earlier about the impact on populations that are racialized, excluded, have lack of access to resources. This layer of, proof of vaccination or vaccine passport, depending on kind of the program or access that you want, this is going to affect people to a great degree. Just like COVID hasn't been equally shared, access to these passports or proof of vaccination is going to be something that could adversely affect people who are otherwise disempowered or excluded. But this is definitely coming, and it's been around for a long time for other types of diseases. When I travel to certain countries, I need proof of vaccination. When I was a medical student, I needed proof of vaccination for hepatitis A and B and chickenpox. I mean, there are places where this makes a lot of sense. And I think with COVID, the growing consensus is it does make sense in this situation as well.
Thank you so much for that. As we know, the National Advisory Committee on Immunization yesterday updated its guidance on mixing and matching second doses of vaccines, saying it's okay to interchange some of them in certain situations. There's a question from Peter here. What are the panelists' recommendations for a second vaccine dose if the first one was AstraZeneca? Also, in light of the new B16172 vaccine, what is the recommended timing for the second shot if the first was AstraZeneca? If anyone wants to jump on that one, Dr. Ogilvie, maybe?
Sure. Yeah, I think we've just had some promising data on heterologous, or two different types of vaccines, and certainly NACI has come out and said it's recommended to have the two platforms. If you have the same platform, mRNA and mRNA, or adeno, those are fine. And we now have sort of ability to mix. So I think that's really promising. And there's some biological underpinnings that actually say that might be actually advantageous. So I think that's really good. What I would say is that in terms of which vaccine you get, I think that's something you can discuss with your primary practitioner. I think there are benefits to all of them, and there are benefits to which approach you get. And as I think we've been saying, the most important thing is to get that vaccine. So if something's available for you, for instance, if a second dose of AstraZeneca is available for you within a timeline, I'd encourage you to get that as it's laid out. I also, though, want to just talk a little bit about some of the extended dose trials and extended dose information. And as you may recall, back some time ago when the data first came out, the vaccines were recommended and at a 21 or 28 day interval. And I think folks need to remember that was the minimum interval, and that's what the trials have been based on. And the trials were done very well, they were done very safely, but they also wanted to make sure they got data out as expeditiously as possible. What we found now is that by extending the intervals a little bit greater than, say, 4 weeks, we actually now have slightly higher antibodies, or even more than slightly higher. So I think that's the other thing. And if you look at different provinces and different regions, you can see a lot of them have gone to the extended interval, but they're making that second dose available sooner than, say, 16 weeks or sooner than, say, 12 weeks. So I'd really encourage folks to look at what's going on in your region, your province, and try to follow those recommendations. I know in my home province of British Columbia, we have accelerated access to our second doses, and I think that's really great news. But I also think people should rest assured that by having the interval greater than sort of 28 days, they're actually not only getting as good protection, but probably slightly better protection. So that's also very good news for folks.
Dr. Halperin, did you want to add to that?
No, I agree completely with Gina that, I think in many cases, the decision will be made by what the province has available, because the vaccines are procured by the province from the federal government, and some of the vaccines have expiry dates. So the provinces are updating their supplies. And so there may be some places where a mixed schedule may be required because that's what the province has available. And the important thing about the NACI statement and the data that's coming out is that that's not only safe, but it's effective. So I think people can rest assured that what the province in each of your jurisdictions is going to be offering you is following the guidelines of a national body, as well as the data that's available. And that data is being updated every day, every week. So if people are concerned that, well, 2 months ago you said this, it's good news that the recommendations have changed, because the recommendations are following data as it accumulates. And that's very reassuring that people and governments are not getting stuck in what they've been doing, but they're responding to the data as it comes available.
And Andrea, if I can just sort of follow on to what Scott said, I think people have had what's been exciting this year is people have had sort of a front seat to science, and they've had a front seat to sort of how science goes forward. And I really want to underscore that by the evolving nature of the guidelines, that actually, I just want to underscore what Scott said, that actually shows that public health and scientists are working together to actually gather the latest information and make sure that the policies are actually evidence-based. So I think sometimes folks say, oh, a change, oh, is that because you weren't sure what we were doing? And I think actually a change actually shows that we're getting even more information. And that is science, and that's how we build health policy. So that's actually a good thing. So I really want to sort of echo exactly what Dr. Halperin said.
And to add to that, that's nothing new. It's just that now everybody has that front seat because, you know, the public is much more interested, and the media is responding that by, you know, having that information. This type of activity goes on in the background for every new vaccine or medication that's introduced. And one of the biggest criticisms has always been that it took too long for practitioners and public health to follow the updated data, that we weren't on time enough. And that, if you go back in the literature, you see how they're, you know, saying sometimes it takes 5 to 7 years for the practice to catch up with the data. We're actually doing it the right way now, in that everybody's very attentive to the data and are making changes soon, so we don't have that long lag period.
Thank you so much for that. Dr. Lafontaine, a lot of your work has centered on community-driven initiatives. We're at 58% of the population having received 1 vaccine dose right now. We've seen people lining up for hours and overnight to get their vaccine. People seem to be very eager and willing across the country. In coming weeks, though, the pace will slow down, and we will be left at some point with a group of people that, for whatever reason, might be a little bit more hesitant or reluctant to get the shot. Some might steadfastly refuse, some still have some questions, some might have some logistical barriers to getting the shot. How do we reach these people?
I'll frame this within something that Dr. Flood said earlier, which is the virus doesn't care about what you look like or where you live or all these other things. The science is the science and the virus is the virus. And so I personally think the place that we need to focus is on people and how they communicate. You know, we've done a great job at taking science and showing people in real time how it develops and how we use that to inform public policy. But we've also shown that communication at the governmental level when it comes to politics and health is very, very bad across the world. Leadership has not communicated a clear way and clear expectations of what's going to happen. And so you understandably have lots of Canadians who are sitting back and asking, you know, what is actually going on? Is this safe? Is this something that I want to participate in? And having these conversations with people that you trust is extremely important, but also making sure that we get back to looking at factual data. You know, there is objective truth in all of this. When you look at data sets that come out from vaccine trials and, you know, public health data, we know that certain things work because they're grounded in science and real-time evaluation. And that's a lot different than, you know, me as an armchair epidemiologist. I'm an anesthesiologist by training, but I'm an armchair epidemiologist like everyone else in this country right now. And we need to take a step back and just realize, you know, expert opinion is still expert opinion. We do have to bring that into the choices that we make, and then create those spaces for people to make choices. You know, I understand why people are vaccine hesitant. And the biggest barrier to people entering these conversations, I think a lot of times, is them feeling that if they have these conversations, they're going to be seen as, you know, less intelligent, immoral, you know, an extreme political person, et cetera, when these are just human questions. And so I really encourage anyone who has vaccine hesitancy right now, think about the sources that you're using to make your decisions. Find people you can trust, reach out to your healthcare providers, reach out to persons on social media that, you know, are part of these groups that are trying to get the message out. I'll tell you that personally, I encourage all my family and friends and colleagues to get vaccinated. It is the way through this pandemic. It is safe. People are making decisions and being thoughtful and careful as they move forward. And we can all get through this together, even though the effects on each of us will be a little bit different.
Thank you so much for that.
If I can add to that, I think Dr. Lafontaine has really laid out some really important thoughts. And I just want to add that we also have opportunities of of appreciative inquiry, or where things have worked. So we've seen in many communities that were thought to be vaccine hesitant or have some concerns with vaccines, actually folks lining up 4 hours to get their vaccine. So what can we learn from those communities? We need to maybe target more programs in those communities. We need to have more vaccine. We need to have Lawrence Lowe led the clinic that went for 24 hours. So people who work shifts could come. So we also have lots of lessons that have shown how things can work well. And so we also need to be super attentive to those. And I think those of us who spend a lot of time in this world, we also know that the type of conversations, the type of peer leaders, the type of ways that you can actually improve uptake. So we also need to listen to those and apply the same sort of rigorous evaluation to those programs so that we can send them out through the country to those communities where we may have lower uptake, and the lower uptake may not be because of hesitancy. It may be because of things like access and the timing of the clinics and the expectation that people have to go to a place that, you know, they need to find childcare and they need to pay for parking and they need to take time off work. So also thinking about what has worked and make sure we spread that and use those lessons as well.
You know, I'll just add to what Dr. Ogilvie kind of just said and just underline. We project onto demographic groups and other populations that we label as vulnerable that they're going to act certain ways. And from what we've seen through COVID and adoption of vaccinations, we actually know that to a great degree, that's not true. You know, First Nation communities have adopted vaccinations at extremely high rates. You know, and these are groups that often carry the burden of you know, the projected bias that they're just not interested in their health, or they're going to be vaccine hesitant or other things. And so it really gives us a space to ask those questions, just like Dr. Ogilvie mentioned, and re-explore whether or not those biases that we projected onto communities are really there. I think a lot of persons who are vaccine hesitant are sometimes mislabeled. You know, they just don't feel heard. They don't feel engaged. You know, they're confused because they haven't found someone that they can trust. And so I think in this discussion, we just need to be careful how we label people and really let their actual fears and concerns kind of come up to the surface.
Thank you so much for that. This is from Patricia S., who writes, in Ottawa, an outbreak at a long-term healthcare home was announced on May 19th. As of May 26, 35 people, 25 staff, 6 residents, and 4 visitors have tested positive, and the UK variant has been detected. Some of those infected were fully vaccinated, but 29% of the staff had not been vaccinated. Going forward, should local health authorities in Canada prohibit all unvaccinated staff and visitors from being in the same room as a long-term healthcare resident, regardless of the resident's vaccination status? Professor Flood, could you take that one on? Oh, you're on mute.
Sorry, novice mistake there. This is another use of a vaccine passport or a vaccine certificate is as a sort of condition of work. So Dr. Lafontaine was talking about as a medical student having to show proof of vaccination of certain for chickenpox and other things. This is a difficult question in the context of long-term care workers because they've already been through so much. You know, just as the population of folks who live in long-term care homes have had just the most god-awful time through this pandemic. So to have the workers there, and a lot of them are older people, often women, often racialized groups. So when we're talking about requiring proof of vaccination, you know, we need to realize the population that we're talking about. But on the other hand, the risks for the folks living in long-term care homes, the residents, are so acute from COVID-19. It seems to me that balancing these things, that it is reasonable to require proof of vaccination from long-term care workers. Going back though to some of the things that Gina has spoken of, it is essential though that we do everything first to make sure that everyone who is willing to or could be helped to understand that they should be vaccinated we do everything to make sure that there are no barriers to them being vaccinated, that they have had every opportunity. And, I think that a lot of folks, forget that it's really been a kind of a Hunger Games kind of thing going on to get one's vaccination, at least in Ontario. Like, it's just ridiculous what people are having to do to actually track down their vaccinations. So this isn't, and to get their second vaccination, we're talking about that now, but people are exhausted and tired from just this whole process in Ontario. So I think we have more to do there to make sure that people are easily and able to get their vaccination, that it's offered to them, that they're not having to hunt around for it like some crazy demented person. I just want to read you a little quote from someone who I know whose dad is in a long-term care home about the situation for the residents there, just to remind us what we're really dealing with. So she wrote on my Facebook feed, "The situation in long-term care continues to be utterly ridiculous and frustrating. Currently, my dad is being confined to his room for 3 weeks because 2 staff members tested positive for COVID. My dad and likely nearly all the other residents in his home are fully vaccinated. Being confined to your room means no showers and spending 24 hours a day in one room alone. It's criminal at this point. The worst part of it is that the staff are not required to be vaccinated. So you have unvaccinated staff bringing the virus into the facility, which then confines the residents to the rooms. And you have fully vaccinated family who aren't allowed in at all. He would have been better off in prison." So, that's the other side. So we have, two kind of issues that have to be balanced here. I think on the whole, that it's reasonable to require long-term care workers to be vaccinated. But Gina may have some really good thoughts about how to encourage folks to get out there and to support them to be vaccinated in those circumstances.
Yeah, and I think, thank you, that last sort of picture really, I think, captures it and what we owe to our seniors and what we owe them, as they're living in facilities. And I think, as you said, we need to make sure when you're thinking about public health and making things a mandate, you have to make sure that you've done absolutely everything to encourage people and to get the intervention needed. And as Dr. Lafontaine said, as in medical school and as part of medical practice, I'm expected to get influenza vaccine and a whole bunch of vaccines, and I have to document proof of that. So this isn't something unusual and we do have processes for these. So I think this is an important conversation that we have going forward. How do we support folks to get the optimized vaccination rate in these settings?
Dr. Lafontaine, did you want to add to that?
Yeah, just to layer on top of those really important comments, working within hospital settings, I've watched patients pass away without being able to have family present, because of visitor restrictions. The whole reason why we scaled down surgeries within hospitals was not only because of physical capacity, but also healthcare worker capacity. And so I strongly feel that there's an obligation for persons who provide care to the most vulnerable. And I think coming to the hospital, there's few situations where you could be more vulnerable, to really think about getting vaccinated so they can prevent adverse effects from, rolling down the hill. I talked quite a bit about the burden of, change in all of this and the burden of pain. And it always goes from people who are in powerful positions down to those who can't make choices. Long-term care in hospital. I mean, these are Canadians and individuals who can't really just leave. They're stuck where they are. And so we focus so much in this question about individual rights when we really should start to enter into the conversation about our responsibilities to each other, our obligations to each other. To use a silly analogy, I mean, I have to wear pants at work, and if I showed up at work without pants, I wouldn't be able to go practice. People would stop me and there'd be no question about whether or not they'd stop me. And I know it's not exactly the same, but there are restrictions placed on us when we go to the places that we work and live. And it's not unreasonable in certain situations to make choices that benefit those around us, even though they do restrict the way that we live day to day. And honestly, I think that that's the Canadian thing to do.
Thank you for that. We have several questions about herd immunity that I'm just gonna smoosh into one question. Is it achievable, is the question. What is the threshold for it, and what role do children, variants, etc., play in this goal of achieving herd immunity? Dr. Halperin, could you take that one on?
Sure, I can try. So, I mean, that is the million-dollar question, is herd immunity, and can we achieve it, and at what level? And we don't know that yet. Modeling, we think it's probably up in the mid 70% range of vaccination when you add in the 5 to 10% of people who might be immune from prior infection by the time we got the vaccines. But remembering that's likely to be, that's 75% of the entire population. And if we're not immunizing children, that adds another, 75% means you actually have to have closer to 85% of the population immunized in order to achieve 75% of the total population. While children are certainly getting infected, they account for 10 to 15% of the cases. They're not as severe in most cases, except for the very, very young. But still, they are probably involved in the transmission from person to person. They may not be the super spreaders like they are with the flu, but they are involved. And therefore, one needs to make sure that they're protected as well in order to protect themselves and others, in order to achieve the situation where the virus does not have enough susceptibles in the population to continue to spread. We think it's a race between getting that level of population immunity before there's enough variants that occur that escape the vaccines that we currently have, and we have to start by achieving population immunity with a modified vaccine. So it is a matter of how quickly we can get people immunized, which is part of the rush, where everybody's trying to do this as fast as possible, and to get those second doses in as soon as we can, in order to try to decrease those numbers. Children we're already have vaccines available to adolescents and pre-adolescents. And we certainly need those school-age children as well to be part of that. That's going to be still probably 6 months away before we'll have vaccines for those age groups. And then infants probably a few months beyond that. So it's going to take some time, which is why we really need to get very high levels amongst other populations until we have vaccines available for those children.
Thanks so much. Question from Tobe. Can an adult with 2 doses of Pfizer be an asymptomatic carrier of the virus and pass it to others? Dr. Ogilvie?
Yeah, thank you. That's actually such an excellent question. And I think we want to just remember, and Dr. Halperin outlined this, we have about a 1-dose efficacy, just a little bit north of 80%, 2-dose efficacy about 90, 92%. So what that means is, and we need to remember in the vaccine trials, the endpoints were folks who had a positive test, but also had symptoms. And that's what we were happy that that's what the vaccine trials focused on, because that's what we want to address in terms of the control of COVID-19. But what that means is that the COVID vaccine, like many vaccines, is not 100% effective. And what that means is it doesn't protect us against every single infection. So when you look at a population, there will be folks who've been fully vaccinated who will develop the condition and potentially pass it on. So that's part of why what we were just talking about in terms of herd immunity, it's so important we get as many people vaccinated as possible, because there will be folks who will acquire the infection and who potentially can pass it on. And that's why it's also particularly important in settings like long-term care, where folks can, even family members who are fully vaccinated, can still pass on the virus. So yeah, this is part of the vaccine in that we know that it's very good, but it's not perfect. And so that's why we need as many people to get vaccinated as we can.
Thanks so much. We have another question about workplaces. Possibly for you, Professor Flood. It's a question from Barry. How might health authorities coordinate with occupational health and safety regulators to ensure we have safe workplaces upon reopening?
Yeah, I think this is a really interesting question about whether or not different employers will require their employees to be vaccinated before they come back to work. I've said to my university, it's kind of a question between ventilation and vaccination, from what I can tell. Your V versus your V. Are you going to invest, heavily in proper ventilation systems? And for some places and some of our old buildings, it's pretty tricky. Or are you going to start to think about requiring proof of vaccination from people before they arrive? And obviously, this is an incredibly difficult and hot topic. So again, on the one hand, you have, people concerned that they may be sort of forced to basically be vaccinated if they want to attend university. On the other hand, you have people who can't be vaccinated because of underlying health conditions, or perhaps they've still got small children at home who can't be vaccinated. And so, they won't be able to participate, for example, won't be able to come to work in person, to come to university in person. So it's a balancing of these two things. Certainly there are other measures that we can take. As I mentioned, ventilation, we could continue to require social distancing, masking, and all these kinds of things if we don't require vaccination. So it's going to have to be a balancing of things. And I think in different workplace environments, folks might have to make calls one way or the other depending on their circumstances. So again, if we go back to the long-term care scenario where you have obviously very high-risk people, in that situation, it seems to me a requirement for vaccination should be there. And others where the risks perhaps are not so high, perhaps one doesn't need to require that, and there are other things that could be done to make the workplace safe enough from that perspective. Hope that answers the question.
Thanks so much. We have a question from Mark about dosing intervals. He writes, I get that one should follow provincial guidelines, but what should people who have had their first shot do if they have appointments for their second shot 16 weeks after the first? Should they wait? Should they try to get their second shot earlier? Is there an imperative getting the second dose earlier? Dr. Halperin, if you could take that one on.
Sure. So, I mean, the 16-week interval was adopted by most of the provinces on recommendation from NACI in order to try to get the most people immunized as quick as possible, to get their first dose in. And it was anticipated that would give the highest level of biggest bang for the buck in terms of the population protection by getting that first dose in. Everybody's achieved and is exceeding the rates that they initially predicted by several weeks to a month. So most provinces have now announced that they are already moving their targets up. So those of you who have an appointment for 16 weeks, now each province is going to roll it out a little bit different. Some have announced that they are going to call back highest risk individuals first. Others say they're just going to do it based on, the first people who got immunized, they'll start shortening those intervals and gradually catch up, because they say that they had initially rolled it out in a priority type of way, first with some healthcare workers and then later by the older individuals and age related. So I think if you just wait for your province, I think most people who have a 16-week appointment are going to get it at 14 weeks or 12 weeks. I don't think you need to go out and try to search out vaccines. It's making people crazy to try to worry about this. I think you know, the vaccines are very effective with that 16-week dose interval, but it's not being left that way. So people are starting to shorten those, provinces are starting to shorten those as the vaccine is more available, because vaccine has been delivered at a faster rate, and we've achieved higher rates of uptake rates faster than we expected. So all is going well, and those intervals will be shortened.
Thank you so much.
Can I just jump in, Andrea? Because I think I just noticed from what I see from folks discussing this is that there's just a lot of uncertainty about, you know, if you've been booked for 16 weeks and now they're recommending it to be earlier, do you just, you know, will they come back to you and let you know, or do you actually have to do the Hunger Games thing and try to, you know, track this down yourself? So I think just to go back to this problem of communication and you know, just a confidence that the government actually has this under control. I think there's a lot of concern about that. You know, people are exhausted and tired and fraught, and they really don't need to have to be signing up on, you know, dozens of pharmacy websites to have to try to track down their vaccines, which has been the case in Ontario. I know that hasn't been the case in Halifax, because you've had a much more sensible approach, but for folks in other parts of the country, it's been really just ridiculous.
Thank you, Professor Flood.
Commentary. And
a question from Jill. As a parent of an adult with severe cognitive disability, autism, and epilepsy, who's living in a group home, the prison analogy rings so true. And that population cannot understand why. They just see that their families have abandoned them. How do we get that population addressed on equal footing with the other vulnerable sectors? Dr. Lafontaine?
So first off, to Jill, I'm really sorry that your family is going through this. I have a son with learning challenges, and I can't imagine how he'd function without his siblings around and us there with him. So I hear your story, and this is a problem. I think one of the things that we've discovered through the vaccination campaign among First Nations, Métis, and Inuit peoples is that there are more considerations than what we sometimes talk about. You know, we brought the immunization age down within Indigenous populations because we recognized that multifamily households were not only a reality in places that had lower numbers of homes available, but also that was part of the social structure that existed. You know, we needed young people to go to places that elders lived in order to help support them and help them kind of work day to day and be supported both emotionally and physically. And so this reminds me a lot of the way that we've created, you know, arbitrary guidelines on restricting people from seeing loved ones without thinking through the adverse impacts that happen as a result. The way that things were changed for Indigenous communities was by amplifying these stories. And I think we really need to talk more about the reality that, you know, adult persons who have cognitive issues or other types of chronic diseases, that walling them off and not letting them see family has really, really bad impacts. You know, we talk about this more and more with, you know, kids going back to school. I mean, this is the same sort of issue in my opinion. And the way that we're going to change it is by talking about it more openly and have people both weigh the science with the human impacts. And I think when those two things meet, we get the best types of plans. And so this is just part of, you know, the science growing, us starting to get past the really scary part of this pandemic where we can be more thoughtful. But once again, Jill, I'm sorry this is happening to you, and I'll help amplify this message. And I know lots of people on this panel will as well.
Thank you,
Can
Dr.
I jump in, Andrea, to say, I think part of what you see here as well has been sort of the articulation of guidelines and rules in hospital and those kinds of settings just dumped over into residential settings that are not hospitals, but actually where people live, such as in long-term care homes and care for children living with disabilities and so forth and so on, and the mentally ill and so on. It's a different context. And a lot of relatives in those circumstances aren't just family, they're also the primary caregiver. They're the primary caregiver to their loved one in an institutional setting, right? They're the ones that are actually in there most days doing a lot of those different things. And so, you know, we really, I think this is a problem that we forget, you know, that in our system of health and healthcare, that these are all the component pieces of it. And that we have to be aware of how these pieces work in order to figure out the best set of COVID-19 restrictions or in response to any other pandemic that might happen in the future. You know, that these are pieces of the puzzle that have to be accounted for. And then so in my view, you know, the wrong call was made about excluding the caregivers of people from these homes when they should have been part of the bubble, and that should have been figured out to permit that.
So just to add to what Colleen just mentioned, I think we take for granted sometimes just how much families do in caring for loved ones, whether they're in acute care, long-term care, or home settings, you know, and the good things that happen in our society have been amplified by COVID, you know, us taking care of each other in certain contexts, us caring about each other, us sharing information, but a lot of the gaps and cracks that existed have also gotten a lot wider. And, you know, sometimes you have elderly patients on the ward who have their, you know, semi-solid food fed to them by a family member. And when that family member can't come into the hospital, that patient doesn't get fed, you know, and you have an understaffed ward where people don't have the time to deal with the day-to-day things and only focus on the emergencies. That ends up being a very dangerous situation. And so that reaches across different places where people live and receive care. And I think we have the chance to be a lot more thoughtful and, just like Colleen was saying, really understand how things work. Because I think we assume that things worked a different way than they ended up working.
Thank you so much, Dr. Lafontaine and Professor Flood, for those very thoughtful answers to some very important questions. I note the time, we will have to leave it there. But on behalf of the Globe and Mail and the Royal Society of Canada, I would like to sincerely thank our panelists for their time and for sharing their expertise here today. Reminder to the audience that you will receive a link to the recorded webcast. And thank you so much to our audience members for joining us today. Thanks so much. Stay safe.